Okay, we're going to go through the Thompson negative today. We focused on the Deerfield positive previously. Now we're going back to the negative. Okay, let me show you the slides. Now, this is the protocol for the negative. So we discussed before that in extension, one leg is short, and in flexion, it remains short. Okay, that is a sign of Deerfield negative. Okay, so in that case, we should go to the cervical syndrome before going to the sacrum. Okay, so this is the new concept, the original Thompson that we're going through in this second batch of DSC. So for the previous batch students, you should go back, go further into this next batch protocols. Okay, so this you should know the original in order to go to the advanced or new types. So my studies was based on this original textbook. I'm not supposed to share this to anybody because this is a closed group for only the registered chiropractors, international chiropractors only. But if you can keep it to yourself and promise not to share this outside the class whatsoever, I could share these PDF to you guys as a secret. Okay, so if anybody wants this PDF, the original PDF, just give me a message on WhatsApp, okay, individually, because I can't share it publicly. Okay, so this Deerfield negative, you go to the cervical syndrome before you go into the sacrum. And this sacrum adjustment is a little bit different from the previous. Okay, after that, if there's after correcting the cervical syndrome, including the bilateral cervical syndrome, that is the occiput extension dysfunction, we go to the sacrum. And if there's a torsion at the sacrum, we will have to find the 4 trigger points that is associated to the AEI sacral base. Okay, so if there's no trigger points, more than 2 to 4 trigger points that is associated to this Deerfield negative, if there are no trigger points, we go to the L5 rotation. Okay, so the L5 rotation, we have to correct the L5 rotation instead of correcting the sacral torsion. So you will do either the sacral torsion adjustment or L5 rotation adjustment. Okay, if it is negative. Okay, after correcting the L5 rotation or the sacral torsion, you go to the SAC. Okay, the SAC is the adjustment that we did in the previous Thompson techniques. Okay, but the original Thompson said those adjustments that we did in the previous course is after correcting the original torsion type, sacral torsion. Okay, so in other words, you will have to do two adjustment for the sacrum. Okay. The one that we're going to do first, and after that we go to the leg chest test, and then if it is still um, Deerfield negative is still present, we go to the SAC, okay, adjustment. Okay, so after that we go to the upper lumbars and thoracic. Okay, so in the previous course I taught everybody that if it is Deerfield negative, we go to the cervical syndrome and then go back to the sacrum. And that was the SAC that we treated. Okay. And if it is Deerfield positive, we go directly to the PI ileum for the previous course. But in this original Thompson techniques, either if it is Deerfield negative or positive, we always go to the cervical syndrome and check if there is any positive findings of the cervical. Okay, so that is very important. Okay. So we will discuss about the cervical syndrome again next week. Okay, and then go on to the other lumbars and thoracic issues. So let's this just a minute down page. So this is the Deerfield negative adjustment. So one leg short in extension, same leg remains short or may become shorter on flexion, and no cervical syndrome involved. Okay. Then we go to the sacrum. Okay. If there's a sacral issue, we'll have to find at least two of these trigger points. So that is an attachment of the hamstrings, medial hamstrings. Okay. So the pubic tubercles, ischial tuberosity, the medial tibial condyle, and the PSIS. So there must be at least two of these trigger points if there's a sacral torsion. If there are no trigger points for the sacral torsion, we go to L5. Okay, then we have to palpate L5 rotation and adjust that. Okay. So you have to remember that the cervical syndrome has to be corrected before going to this sacrum. Okay, and if there's no trigger points, we go to L5, and after that we go back to the SAC. It's a different sacral dysfunction adjustment. Okay. Okay, so there are two parts of this adjustment. It is both in supine position. Okay, it is both in supine position. So first, we're going to have the patient in a supine position, and we're going to contact on the posterior ischium with number 8. That will be the lateral knife edge. It says number 8, okay? So it's the lateral knife edge. And we're going to stabilize the ASIS with our superior hand. So our contact hand will be the inferior hand on the ischium, posterior ischium, as we stabilize the ASIS with our superior hand. And the adjustment will be made with a drop. Remember that the drop piece, if there are lumbar piece and pelvic piece, we should lift them both. Okay. And the adjustment will be from I to S, from the ischium up, so that we could correct the pelvic that is dropping down. Okay. So AI, we're going to correct the AI using the ischium. Okay. So we drive it we're going to contact at the posterior ischium. So that will drive the pelvic to from AS to PI, involving including the sacral base on the positive side. Okay, and after that, so this is correcting the side, actually the side bed of the sacrum. Okay, and after that, we're gonna contact on the inguinal ligament on the positive side with our thenar eminence. Okay, and it's about 1 or 2 inches away from the pubic symphysis, because the pubic symphysis has a trigger point that is very tender. You should avoid contacting on the pubic symphysis. Okay, so the inguinal ligament close to the pubic symphysis, but 1 or 2 inches away. Okay, and what we want to do is correct the ileum on that positive side medially by correcting the inguinal ligament with a torque medially. Okay, so you have to remember that AI sacral base has a connection with the ileum on that side, the same side, that is IN. Okay, is ASIN. But in this original textbook, it doesn't have any writings about the AS ileum. It says only IN. Okay, so we want to correct the ileum medially in this anterior aspect to open the posterior aspect, because IN is a medial shear of the PSIS. So we're going to use the inguinal ligament to correct the IN ileum. Okay, so we have to do 2 adjustments. Okay. So this comes first before going to the SAC technique that we did in the previous course. Okay, so we're going to talk about that later. Okay, so first we should do this. Okay, and yeah, if it is positive, we do the technique that we discussed last week. Okay, okay, so and these are the cervical syndrome we're going to talk about next week. There are alternate adjustment moves using drop tables, and this is the alternate way to adjust the inferior AI sacral base, okay, in a prone position. So it is better to have the patient stay laying down in a prone position instead of do it in prone and supine and prone and supine, because it will give too much impulse to the brain. Okay, so that won't be accurate to find the leg length test. Okay, so it is better to have the patient to stay prone, especially for a patient that has severe symptoms. Okay, it isn't easy for the patient to flip over. Okay, and also it is better for the drop table. If the patient lies down multiple times on the table, the drop table may wear out very fast. Okay, so chiropractors should be very careful to care for the drop table. That is your tool, and that is also your partner. Okay, so I take care of my drop table every day, or every day multiple times. Each time I treat a patient, I wax my drop table. It's always clean 100%, so I can use it 100 years. Okay, so we could do that. I'll show you how to do this in a prone position. Okay. Okay, so for after doing that, we could go to the sac. Okay, sac is doing the, you have to, after treating the sacral torsion that we just talked about, we go to this sacral leg analysis. So we're going to stabilize the sacrum so that the ASIS or pelvic will not be lifting when the patient extend their hip joint with the knees fully extended. Okay. I'm going to ask the patient to lock their knees in a prone position and extend their hip joint as much as possible. Okay, as we stabilize the sacrum. Okay, and the positive finding is that the leg does not raise up enough. Okay, so the lower leg is the positive side. Okay, so that means that the positive side sacrum will be AI sacral sacral base. If there's no findings, we won't adjust it. But it says here, if it is no, even if it is only a few inches difference, if it is noticeable, then we should adjust it. It is very good to adjust this to correct the whole body balancing. Okay. Before going to the upper components like the lumbar or thoracic. Okay. So this is the previous adjustment. I showed you this in the phase 1. Okay. So we can go back to this again. Okay. And there are also side posture adjustments for the sacral sac. So we could do that as well. Okay. So let's finish up with this. Just a minute. So I will demonstrate on Tomoko. So you can remind me if I missed something, okay? I might forget. When we do the analysis, leg length analysis, the headpiece should be remain flat, leveled. Okay, the lumbar, the pelvic piece, and the lumbar, thoracic, and headpiece is flat. It should be flat. When we correct the cervical, it should be flexed about 10 degrees. The cervical piece, headpiece should be flexed, so the weight of the head will do a traction. So like I said, we're gonna have, we did this before, so we're gonna unlock the knee, lifting the leg a little bit, okay? A few inches, 1 or 2 inches. This is not, don't flex too much, okay? Now, without dorsiflex or plantarflex, we're gonna bring the inversion and eversion into flat, okay, even, okay? And we're gonna see in this with our dominant eye in the center, we're going to see that I can see that the right leg is short in extension. Now I'm going to flex 90 degrees and do the same routine. So she has a Deerfield positive, but let's say she has a Deerfield negative on the right side. Okay. Because I corrected her Deerfield negative so multiple times because I'm doing so many onlines for many courses, and her negatives actually corrected. Okay, but let's say she used to have a negative on the right side, okay? But now let's say she has a right short and short. Let's say it is short. Even if it is positive or negative, we're gonna see the leg length in extended position, and have the patient to look towards the short leg. Okay, begin with it, and it remains short. Okay, look to the left. Uh, bring it back to neutral and have her relax for about 3 seconds, and then look to the left. And it remains short, but that means that she doesn't have cervical syndrome. Okay. Okay. So it is short in extension. That's why we did that cervical syndrome test in extension. Okay. But she doesn't have any cervical syndrome, so we could go on to the sacrum. Okay. So if she has a right AI sacral base, if I want to correct it, I have to find the tender points, the trigger points at the medial condyle, compare with the right and left. Let's say this is tender. Okay. We should have to find some tight spot and do some massage to it, stimulation, and ask if it is tender. Now we're going to the PSIS. We'll do a mild, find some nodule type, and if it is tender, that is 1, 2. Now we're going to the posterior ischium and do some massage to it. If it is tender, okay. And we don't have to do the pubic, okay. So the pubic is the 4th because she's in prone position and she's a female, okay. So at least in a prone position, 3. Out of the 3, we should find at least 2, okay. So medial condyle, she has a tender point, and the PSIS she has, okay. And the 2 posterior ischium she doesn't have, but that is 2, okay. Okay, so now if she doesn't have any tender points, we're going to palpate L5 mammillary process and do the rotation test, okay. Or we could stabilize the sacrum and move the spine's process from right to left, left to right, okay. So if it is right AI, Deerfield negative on the right side, the lumboiliac ligament is attached, so it has to be rotating. The spine's process always rotate toward the same side of the sacral torsion. Okay, so AI means that the right sacrum is anterior, that is pulling, and the pelvic is AS. Okay, so the spine's process will rotate towards the AI sacral base side. Okay, if it is a Deerfield positive, it will rotate towards the opposite side as the pelvic on the right side rotates posterior. It will rotate opposite side. So if she has a PI ilium on the right side, it will be PL. Okay. If she has an AI sacral base on the right side, it will be PR. Okay. So if it is PR, the spinous process with L5 will move more easily to the right than towards the left. Okay. And if she has PR, I will be on the lateral side of the spinous process rotated side. Okay, so this spinous process is rotated to the right, so I'm going to be on the left side, sitting down. I should be leveled, so I could pull the spinous process from right to left. Okay, so the contact hand will be my pisiform of my superior hand. Find the spinous process with my inferior hand, okay, of L5. Okay, yeah, you can easily find spinous process of L5. Okay. I mean, it's easier to find L4 because L4 is spinous process is larger than L5. So if you can find L4, that's the lowest, the biggest spinous process of the lumbar. Below that, it's a little pebble-like bone that you can fly to L5. Okay. So I'm going to pull the tissue slack from right to left with my inferior hand. I'm going to use my phase-4 to contact on the right side of the spinous process because I want to pull the spinous process with my phase-4, okay, with my left hand, right to left, without pressing the anterior. The anterior pressure is just to drop the piece. Okay. Now I'm going to grab my contact hand with my indifferent hand like this. So I'm going to contact hand is my left hand, but I'm going to drive it this way with both hands like this. Okay. So I'm going to lift the pelvic piece and the lumbar piece. Okay. I can ask her to breathe in, breathe out. Okay. Sit, breathe out, breathe in, breathe out, and then just like this. Okay. So you should drop it. So I'm going like this. This is just supporting. I'm not contacting with this hand. I'm contacting with my superior hand, phase-4. So you can do that 3 times, maybe 3 to 4 times, okay, at most. Okay. And always go to the leg test. Leg length test is equal now, so I'm gonna unlock it, flex it twice. It's shorter again, so the Deerfield negative remains. Okay. And if she has a trigger point, we should not adjust L5. We should go to the sacrum. Okay. So sacrum in a prone position, I should stand on the positive side as I use my medial knife edge under the, I'm going to hook the ischium process from I to S, and I'm going to drive it superiorly. Okay. So also I should bring both lumbar piece and the pelvic piece up. Okay. So contact and drive it up because the right sacrum is inferior. Let me drive it up like this. Okay. So that is an alternate way of adjusting the sacral torsion like this. Okay. But the original is in a supine position, so we're going to do that. Okay. Okay. Okay, so in this supine, we have 2 steps. Okay, the first step is bringing the sacral base on the right side up. Okay, we're gonna treat the right side bend of the sacrum. So we're gonna contact with our number 8. Okay, number 8 is here when we do the cervical. It's the same here. Okay. We could drive the ischium up like this. Okay, as we stabilize the ASIS. This ASIS is just doing stabilization and helping the table to drop. Okay, so this is forcing it posturally, but it's not actually an adjustment. The adjustment is through my inferior hand. Okay, and we're going to have the patient to flex the positive side, AI side, and I'm going to drive by here under the issue. Okay, as I stabilize, I'm going to thrust up as I drop the table down. Okay, and the lumbar piece and both pelvic piece should be up. Okay, so okay. We'll do that 3 to 4 times. Okay. And that is number 1. Now I have to bring the pelvic into IN towards EX. So I'm going to find the pubic symphysis and the inguinal ligament. Okay, so I want to bring the inguinal ligament close to the pubic medially with a torque. Okay, if I bring the inguinal ligament medially, the IN ilium will go into EX. Okay, and when I do that, I should have the patient to have their feet on the end piece here, so she could flex her hip joint just to relax the opposite side hip joint. Okay, so I do a quick torque. I should use both lumbar piece and the pelvic piece, but she doesn't actually have it negative, so I'm not going to use the lumbar piece. Okay? But for the patient, I should. So I'm going to hook with my pisiform of my superior hand with a chiropractic arch underneath the inguinal ligament, so I could torque it medially in a CW torque. If I torque CW, I can bring it medially. Okay. Some people does it CCW with our thenar. I can do that too because I just want to bring the inguinal ligament medially. So I could do it this way or this way. Okay. Maybe it's easier with my thenar eminence. Okay. So I'm going to torque it CW. Okay. CW. So this is very tender if I contact on the pubic. So I'm going to avoid that and do a very fast torque. So torque this. Okay. This is 3 to 4 times. Okay. As I stabilize the knee with my inferior hand, okay, because it might rotate. Okay. I'm just stabilizing the knee. Okay. And the adjustment with my thenar eminence, I'm going to bring the pelvic from IN to EX. Okay. 3 times. Okay. Okay. That is the correction for the original sacral dysfunction. Okay. And after that, we should recheck. Right length. Always lift it up because it's the knee lock. We have to unlock it. And the leg length is equal. Okay. So she doesn't have any Deerfield negative anymore. So we could go on. Okay. But if it still remains, okay, we should go to the sacral sac. Okay. So the sac, it's all gone now. So I'm not supposed to be doing it, but if it still remains, I should stabilize the sacrum and ask the patient to lock their knees in extension and extend their hip joint as much as possible without the pelvic lifting, just the hip joint. Okay. じゃあ、右足上げてて、膝伸ばします。So see that it's not lifting that much. Okay, 下ろして。Reset, stabilize sacrum, and without flexing the knee joint, こっち上げて。This is much more easier to lift. Okay, that is a finding of AI sacral based on the right side. It's the same finding that I saw previously. Okay, so in that ways, I could stand on either side, and right leg is positive side AI. So I'm going to cross her leg behind her AI sacral base leg behind her contralateral leg and lift the right pelvic off the table. Okay. As I stabilize that, I'm going to contact with my inferior, my superior on the apex from left to right because I want to translate the apex left to right to bring the right sacral base posterior superior. Okay. And my right hand will be crossing medial to the BSIS of the right side. Okay. Just to make a torque. With both lumbar piece and pelvic piece lifting, I'm going to do a quick adjustment. Okay. I should do that 3 to 4 times. Okay. And after that, so it's equal. So the only adjustment that once is the cervical. Others come from 3 to 4 times. The cervical syndrome only once. Okay. It's our properties. Okay. For each segment. Okay. For the others, we can do 3 to 4 times. So for the next session after about 30 days, she can come in, and if she can tolerate, we could do a side posture adjustment for the. In that case, we're gonna have. There's 2 ways to do it, but in this textbook of the original, the positive side down. Okay, so she has an AI on the right side, so we're gonna have her side posture down on the right side. Okay, so こっち向いて座ってくれる? Okay. I'm gonna have her in a side posture. I'm going to flex her upper leg, hip joint, and find the tension between L5 and the sacral base. I feel the tension here. Stabilize that as I pull her lower leg, shoulder towards the sacrum. So I'm gonna side bend toward the right, pulling her shoulder inferiorly, not anteriorly. Okay. Now I'm going to pull her upper shoulder away from the sacrum. Okay. To side bend toward the right. Okay. And without rotating her shoulder and pelvic, I'm going to roll her in so I could stabilize her leg between my thigh and the table. Okay. Lean on the patient in this manner. Palpate the right sacral base and the between the sacral base on the right side and L5. Okay. As I palpate, I'm going to use my soft pisiform on the left, ILA, the apex on the left side, so I could compress the left apex anteriorly as I do a torque this way, counterclockwise, because I want to bring the right sacral base posterior and superior. Okay. So I could stabilize her shoulders as I drop very fast with the torque and small. Okay. this way. Okay. I can use a drop table as well. So it will be less force. You could do that 3 to 4 times. Okay. And recheck, always recheck. Okay. Yeah, wrong position. So if that adjustment was too big, the leg will get shorter. So it's even, and I could reset and see if it is even. It is even, so for this visit, I should not go further to the other adjustments. Okay, if it gets even if I lock it, unlock it, and bring it into flexion, and it's even, and I could have the patient to rotate her head for the right and left. And if it's even, I should not go on to the next segment. I should wait for at least 2 weeks. Okay, I'll call me with it. Even. Okay, look to the left. Medicate it. It's even. So I should not adjust any other parts. If it got short, it's an exception of so we're going to talk about the exception of ear field. Okay. Okay. So that will be all for
Habib sir, try to mute your mouse mic.
what? Oh. Okay. Any questions? So we're doing it one by one as we review the previous. So we discussed about the leg length test in phase 1. In phase 2, we did the Palmer type hand contact and the thrusting skills. And 3, we did the Deerfield positive for the PI ilium. Okay. And today is phase 4. We did the negative for the sacrum. Okay. And if there's tender points, there is no tender points for Deerfield negative. We go to L5 rotation for the spines process. Okay. So this is the protocol of Thompson. So don't mix it up with Gonstead. Don't mix it up with activated method or any other techniques. If you're gonna do Thompson, do it till the end. Okay. Okay. Do nothing else. Okay. Don't mix it up. It won't work. Okay. So if you're going to do AMCT, if you choose to do AMCT, you're going to do the basic protocol of AMCT that we're going to discuss after we do the Thompson. Okay. Okay. So for the Gonstead, you should go back to the previous course videos that I shared. Dr. Armcar should have shared you. Okay.
Yes, sir. Yes, sir. I will share.
Yeah, and we could do more about the X-ray analysis in the practical class when we meet in India. Okay. Okay. Just a minute. Okay. Muscle involvement.
Yes, sir.
Muscle involvements for these dysfunction, we discussed that in the first phase. So it's for Deerfield negative, it's the medial hamstrings. Okay, that is neurological contracting, because if the sacral base is AI, the pelvic will be tilting anteriorly. That will be pulling the hamstring, especially the medial. So the trigger points for the Deerfield negative will be the attachment of the medial hamstrings. Okay. Oh, we discussed that before. Remember? Okay. So if it is Deerfield positive, that will be the rectus femoris. Okay. Okay. So in either ways, if there's a imbalance of the pelvic, that will be stimulating the 1A towards the brain, okay, and that will be making subluxation throughout the body. Okay. So we should go from the cervical, because the cervical syndrome will mask, it will mask the neurological effects. Okay. So you have to reset the masks. Okay. What pull away the mask, so it won't be masking the cervical syndrome. Okay. After that, we go to the leg length test and determine if we're going to adjust the sacrum. Deerfield negative, there must be a tender point for the hamstrings. Okay. If there's no tender points, we're not going to adjust the sacral torsion. Okay. We go to L5. Okay. We have to palpate L5 anyways. Okay. And if it is rotating towards the spinous process, rotating towards the short leg side, we'll be adjusting that. If it is not, we should go to the SAC, okay, SAC that we did just now. Okay, that's also the hamstrings, but there might be no what hamstring involved. It might be the ligaments that is involved, that is pulling the apex towards the opposite side. Okay. So if the ligaments on the left side of the apex pulls towards the left, the sacral base on the right side will decline without the hamstring involvement. Okay. In that way, that right hip joint cannot extend, because when the hip joint extends on the right side, the apex has to rotate towards the extended side. It is fixated this way, so we're going to adjust the sacrum like this to loosen the sacroiliac or sacrotuberosic ligaments on the left side. Okay, it will release like this. Okay, so the hip joint can extend. Okay, that is a same finding as in other chiropractic techniques. Okay.
It's already in group.
Yeah, the books are already the books that I sent you is the the Thompson technique books. Okay, so these muscle involvement is all in that book. So in the first phase, I asked all of you to read through the materials, and especially the Thompson book that we shared you. Okay. And for the textbook that I showed you today, that is a very secret. I'm not supposed to be sharing to you guys. Okay. But if you have, if you can promise me that you're not going to share it to anybody outside this course, and you're going to be make it private to yourself, ask me individually, not publicly. Okay, because if I do that, I can be.
Yes, sir. Yes, sir.
Okay. So ask me about that individually if you want it. Okay, and you have to promise me that you're not going to share it outside. Okay. Okay. Any other questions? So next week we're going to the cervical syndrome again, and we'll do it specifically. Go to the cervical syndrome and bilateral cervical syndrome and overcompensated cervical syndromes. And if we have time, we could go to the extras. Okay. Okay.
And everybody try to join the meeting.
Yeah, please. Yeah. So these. So like everybody's asking me these questions during the course. These questions are very good. So if you have any questions, don't hesitate to ask me in this during the online. It is very good for everybody. Okay. So don't hesitate to ask. Okay. It will profit everybody. Okay. So if you do that on WhatsApp without seeing this video on time, that will be very annoying. Okay. So when you have questions, you should ask online so we could record it. Okay. For the next students as well, not just you. Okay. For everybody. Okay. Okay. So yeah, over active unilateral psoas can produce any kind of dysfunctions, Deerfield negative or positive. The psoas and the erector spinae and the piriformis muscles. We're going to talk about that later on. So that most of the cases that will be base P, most of the cases. Not always. It may be Deerfield negative or positive, but most of the time, if one side of the psoas contracted, it will make a positive finding of base P, not AI, base P. If it is base P, when we do the extension test for the hip joint, okay, like I stabilize sacrum and ask her to lift her leg off the table like I did, and it doesn't lift over only about a few inches away on both sides. Okay, on both sides. That is a finding by you. If it only lifts a little, okay, it is a finding of base B. In that case, maybe the psoas on both sides is contracted. If it's only one side, it might be the posterior rotation of the sacral based on that positive side. But it may be PI ilium, EX, IN, or sacral AI. It can be anything. Okay, it might be compensating the pelvic region. Okay, that is a very good question as well. So we could go further to that. Those are what those psoas problem is after treating the Deerfield negative and positive. Okay, after. So we'll be talking about that when we do the lumbar. Okay. Which muscles produce base anterior? I just discussed that. It's the hamstrings, right? If it's AI, it's a hamstring. If it is both anterior, both hamstrings are contracting. If it's one side, it will be AI sacral, it's Deerfield negative. Okay. Or maybe it may be the erector spinae on both sides. Okay. But yeah, that is maybe the erector spinae and the psoas muscles is a secondary dysfunction. Okay. Most of the times. So to relax those psoas muscles or the erector spinae or piriformis, it is best to adjust the Deerfield negative or positive sacral faults. Okay, if we treat those negative and positive, those erector spinae and psoas and piriformis muscle will eventually relax. Okay, so if it doesn't cure, we could go on to the psoas adjustment. There's treatment for the psoas using drop tables, okay, and the piriformis muscles as well. Okay, great. Any other questions? Good.
Thank you, sir.
Thank you. Okay, so if you don't have any questions, okay, it was nice, good questions. Okay, if you have more doubts, you could keep it to the next time. You can ask me before or after, even during the online. It'll be very valuable Your questions are very valuable for everyone, like I told you, okay? So we can keep this in recording as well. Okay, thank you. Let me stop the recording.